Thank you. Welcome, everyone, to the 44th Annual Reynolds Finley Historical Lecture. I'm Dr. Anupam Agarwal. I'm the Senior Vice President for Medicine and Dean for the UAB Heersink School of Medicine. Each year, the Reynolds Finley Historical Lecture brings an outstanding speaker to Medical Alumni Weekend to review, assess, and discuss various historical aspects of the healthcare sciences. This year, we are truly fortunate to have an expert speaker, a historian, and a former RN and certified nurse midwife, Jenny Luke, who will present A Century of Maternity Care, Alabama's Highlights and Challenges. I know we are all in for a fascinating lecture today. And now I'd like to introduce Peggy Balch, the curator of the Reynolds Finley Historical Library. Peggy.
Thank you. Okay. So on behalf of UAB Libraries and the Historical Collections Department, I want to thank you all for being here today at what I know will be a most fascinating lecture. I want to express gratitude to the Reynolds Finley Associates and Steering Committee who support our department's programs, including this lecture and the Reynolds Finley Fellowship. Thank you also to the Medical Alumni Association, to Dean Agarwal and the Heersink School of Medicine for co-hosting and collaborating on this event with UAB Libraries. Also, a special thank you to Dr. Wayne H. Finley and the Finley family for their support of the Reynolds Finley Lectureship. This is the 44th annual lecture, and Dr. Finley founded it back in 1980 as chair of the Reynolds Associate Steering Committee. So we're immensely grateful for his continued support and involvement in the success of this lecture and the Historical Collections Department. And now it's my great pleasure to introduce our speaker. Jenny M. Luke trained as a registered nurse at the Manchester Royal Infirmary in the UK in the mid-1980s, and in 1987 began a post-registration course in midwifery at St. Thomas's Hospital in London, qualifying as a registered midwife in 1989. Later, she came to the US to work as an RN on labor and delivery at Parkland Hospital in Dallas, Texas. Although initially intending to return home at the end of her year-long contract, she ended up staying. 1 year turned into 2, and so on. She eventually married and settled in Dallas-Fort Worth. Her interest in the history of midwifery was piqued when she arrived in the US and discovered a great difference in the perception of midwifery between Britons and Americans. And so she had the opportunity to delve into the subject while earning her bachelor's and master's degrees in history. I had the pleasure of working with Jenny during her research visits to our historical collections. She has twice been awarded a Reynolds Finley Associates Research Fellowship, which is a competitive program to fund the travel of scholars who wish to use one or more of our historical collections for their research. Those collections being the Reynolds Finley Historical Library, UAB Archives, and the Alabama Museum of the Health Sciences. Jenny's outstanding book, Delivered by Midwives, African American Midwifery in the 20th Century South, was published by the University Press of Mississippi in 2018 and was supported by a Reynolds Finley Research Fellowship in 2017. It was also the recipient of the prestigious American Association for the History of Nursing Lavinia L. Dock Award for exemplary research and writing in 2019. Her essay on African-American midwife, Margaret Charles Smith, was published in the book Alabama Women, Their Lives and Times. And with the help of a second Reynolds Finley Research Fellowship in 2022, Jenny is currently exploring the complex issues surrounding maternity care provision after the prohibition of midwifery in 1976. Please join me in welcoming Jenny Luke as she presents A Century of Maternity Care, Alabama's Highlights and Challenges.
Hello, thank you for inviting me to speak today. As Peggy was saying, I have been fortunate enough to be the recipient of 2 Reynolds Finley Fellowships, the first of which greatly supplemented my book here, Delivered by Midwives. The second one, just last year, is supporting my current research on more recent midwifery in Alabama. It was never my intention to write a book. It was never my intention to study history. All I wanted to be from about the age of 4 was a nurse. Thank you. Yes, this is me as a staff midwife. This lady sent me this photograph and this nice little note after I'd looked after her when she was having her son. It represents what a midwife is to the people of the UK. Someone who looks after pregnant women, someone who delivers women having healthy, low-risk pregnancies and labours. Somebody who works in the community, in the prenatal clinic, in hospital, somebody who visits you at home postnatally. A midwife there is part of a thoroughly mainstream maternity care team. British people know that. And when I came to the US, I was surprised that people looked askance when I said I was a midwife. I was curious about the difference and the difference in perception between Britons and Americans. And I've luckily been had the opportunity to explore some of the reasons for those differences. Today, I'll try and sum up roughly 100 years of maternity care in Alabama. And I focus on maternity care for Black women because race is so closely connected to the history. And frankly, the crisis in maternity care for Black women demands that we focus our attention there. As it was a century ago, Black women and babies are dying at least twice the rate as white women and infants. I think it's important to review history, to look at what has worked and what hasn't, and allow history to inform the future as much as we can. The general assumption with the history of medicine, in this case, the medicalization of childbirth, is that progress is always linear, it's unidirectional, and it's always positive. It's absolutely foolish to deny the benefits of modern medicine, but the things are getting better all the time approach has to be recognized for its failings, especially given the current situation in maternity care. I say I will attempt to unravel the topic, as it often seems to be something of a Gordian knot, especially in its most recent history. Thankfully, I approach the subject as a historian and not as a practitioner or a maternity care policymaker. So we begin in 1921, when the federal government intervened in maternity care for the first time in response to America's high maternal mortality rate. It was higher than virtually every other industrialized country. Intervention came in the form of the Shepard-Towner Maternity and Infancy Protection Act, whereby federal funds were matched by state funds. And across the South, where maternal mortality was at its highest, and particularly for Black women, the state used the Shepard-Towner funds to license and supervise and train the thousands of Black lay midwives that provided care to their community. From there, incremental changes occurred as more women had better access to physicians and hospitals. From 1976 onwards, the shift towards hospital care and physician-led delivery was complete for all women, irrespective of race and socioeconomic group. The state struggled to manage care for poor and rural women. The cost of care, malpractice insurance, professional turf battles, and healthcare organizational structures all contributed to a multifaceted problem that didn't bring maternal mortality in line with national figures. In the middle time period, the years that bookend the Second World War, we'll look at two interesting projects: the Tuskegee School of Nurse Midwifery and the Slosfield Health Centre in Birmingham. The main objective of this presentation is to provide a broad, high-level narrative history, and we'll break down maternity care into micro and macro components as a way of analysis. I warn you that I have committed the cardinal sin of having too many wordy slides, but my reason for doing so is to highlight the value of Reynolds Finlay Library. And I wanted to include some important quotations that can tell the history much better than I can ever do. Much of the content of the slides is held at Reynolds Finlay or in the UAB archives. The connection between culture and health is well established, and micro and macro elements of care have been identified as a way of addressing disparities in health, particularly in the Black community. This concept promotes the blending of a modern understanding of health with a community-oriented traditional model of wellness. A community approach considers the connection between health and spirituality, the relationship between health and healing, or how health is understood and how knowledge is transmitted across generations. The Black community in the South came out of slavery with a very deeply rooted childbirth tradition, and the enforced segregation following that only cemented that tradition. So applying these terms to the start of our time period, in the Black community, childbirth was managed by Black lay midwives, midwives who shared the rich heritage of the women they served. They were spiritual, trusted, and revered. The lack of alternatives had preserved a culture that was based on resourcefulness and self-help, and a God-given wisdom found in the midwives called mother wit. These midwives fulfilled the micro needs of care completely, but they were without access to medicine. They had no access to macro care. Towards the 1960s, as more hospitals opened across the South, Black women embraced hospitalized, physician-led childbirth. Science drove progress, and macro care reigned supreme. However, the reality of care in segregated and later integrated hospitals was far from ideal, even though the women now had access to macro care. It was as if the pendulum had just swung too far. Logically, we might expect the sweet spot for optimum maternity care to be at the midpoint of the pendulum swing, or the balancing point, where there are equal amounts of micro and macro care. But instead of visualizing maternity care that way, a better way is to see it as the layers of an onion, where macro care is layered on top of micro care. One type of care isn't sacrificed for the other, but just enhances the other. And then it can be adjusted to the specific needs of a woman. For example, a woman having a high-risk pregnancy is in need of obstetric care and state-of-the-art technology, which is in no less need of culturally appropriate care, effective health education, and the type of care that fosters a relationship of trust and respect, and one that facilitates early and consistent prenatal care. We'll keep these micro and macro components in mind as we look at the broad sweep of maternity care. So who were the Black lay midwives of Alabama? Women like Margaret Charles Smith here, who lived and worked in Utah, Greene County. She worked until about 1980. They were reliable, smart, and pragmatic. They were trusted, spiritual, and central to the community. They were fully aware of their ability and their authority, and these were qualities that served them well as they interacted with their local boards of health and local physicians. Despite initially underestimating the lay midwives, generally speaking, doctors and public health nurses were overwhelmingly impressed with their eagerness to learn and their effectiveness in the community. So in the 1920s, with Shepherd Towner funds, the licensing and supervision and training of lay midwives began. The midwives embarked on a series of classes to standardize the care they gave. Topics would include asepsis, a delivery technique, how to prepare the home for delivery, what sort of prenatal advice to give, what sort of danger signs required a call for the doctor. They had to follow the strict set of rules set down in the midwife's manual. And Reynolds Finley has a copy from 1956. I brought my copy, but there's one on display in the exhibit in the library at the moment. Every aspect of the practices was stipulated in the manual. There was absolutely no room for deviation. All traditional practices were prohibited. For example, teas that may have been used to augment labor or massages were all forbidden. And the midwives made up for the loss of those reassuring components of care by the reassuring, trusting care that they gave the women. I hope you can see that properly. The midwife's bag came to exemplify the modern midwife. It was the equivalent of a policeman's badge. It symbolized her authority to practice and had to be kept in absolute accordance with the manual. If a midwife was asked to turn in her bag, it meant that her license to practice was terminated. And vice versa, one midwife we know of handed in her bag in a show of frustration because she wasn't getting the support she expected from her local board of health. Many midwives had already made the connection between hygiene and maternal well-being, but now all saw improvements in the standard of care as they found ways to use cotton and newspaper to make receptacles and pads for the bed, gowns and dressings. In fact, I followed the instructions on the left there to show you that it's actually a very useful, if you have nothing, this is very useful little receptacle. This flap was tucked into underneath the mattress, and the bag would hang, and you could put, keep your delivery, keep the bed clean for delivery. All of these things, as well as the gowns and dressing packs, were sterilized in the midwives' home ovens. In fact, the Mississippi Handbook of Midwifery advises the midwives to put a baking potato alongside the dressings in the oven. And when the potato was cooked, it was presumed that the dressings were sterile. Home visits were a critical part of the midwife's role. They were used to prepare for delivery, to gather all these supplies, and importantly, to give prenatal care and education. Fully half of the Alabama Midwives Manual is dedicated to the home visits. And it was effective because the midwives were trusted and familiar women in the community. And we know that in public health communication, the messenger is every bit as important as the message. Although governed by this very strict set of guidelines, the midwives had to be prepared to deviate. They had to be flexible and ready to improvise such was the level of poverty in their communities. Many midwives report sewing a few simple garments for the baby if they had time in the early part of labor. They fully understood the importance of their role as advocates, and they made sure that the physician met his professional obligation if he was called out to help them. The midwives' authoritative position also made them invaluable in other public health campaigns, such as vaccination programs and dental hygiene initiatives. An important requirement and a significant change was that a woman had to have an examination by a doctor prior to approval for a midwife delivery. This was the first time that many Black women had ever sought physician care during pregnancy. It was their entry into the macro world of medicine. And for the lay midwives, it was a double-edged sword, because they were so good at ushering women into clinics that over time they ceded authority to the physicians as Black women changed their attitudes towards their pregnancies. To ease the transition into the unfamiliar clinical environment, the midwives often went with the women, especially on the first visit to clinic. Many midwives worked in the clinic, and if there wasn't a physical clinic building in their community, one of the midwives would open her home up as the clinic on the day that the doctor was due in town. But the maternity services were inconsistent across the state. By 1950, with the nation's highest maternal mortality rate, 27 counties in Alabama had yet to establish any form of prenatal services, despite it being 15 years since the Maternal Welfare Committee had commanded each county to do so. The Medical Association of the State of Alabama published reports each year. They're held at the Reynolds Finley Library, and they're invaluable at seeing the change or lack of it over time. The tone of the Maternal Welfare Committee reports just shows an increasing frustration year by year. In 1947, the leading cause of maternal death was identified as what used to be called toxemia, now eclampsia. And the entry that year stated that Alabama had a failed maternity care service. And the author sarcastically writes that clearly the Medical Association was willing to accept the "here we rest at the bottom of the pile" status. Time and time again, the Maternal Welfare Committee berated the medical community for its lack of foresight in addressing the needs of the poor. Dr. Thomas Boulware, chairman of the Maternal Welfare Committee and author of the comments in the transactions, knew that providing adequate care during pregnancy was vital, but only one aspect of Alabama's maternity care problem. A lack of education in OB was a significant issue. In fact, mortality associated with physician delivery was hardly better, if not worse, than with the midwives. With 85% of physicians delivering babies in Alabama, Dr. Boulware demanded that the Medical Association devote more resources to obstetric education. And these are the figures he used to support his claim. As the overall mortality rate improved and access to medical facilities increased, his argument was distilled down to providing adequate care for poor Black women, as their mortality seemed intractable and, more importantly, preventable. The leading causes of death were eclampsia, infection, and hemorrhage. Clearly, better supervision of lay midwives was called for, and with it, the acceptance that they were necessary until a better solution was found. The Tuskegee School of Nurse Midwifery was established to that end. It was to train Black public health nurses in midwifery, and specifically to train them to supervise the lay midwives. The thought was that they would be, as Black women, they'd be more effective in the communities and more effective in supervising the midwives. The results were impressive in Macon County, where the maternity service was based. Admission standards to the school were extremely high. The applicants had to be from an accredited school of nursing with at least 1 year of public health experience and with some postgraduate public health education. And keep in mind that at this time, only 20% of schools of nursing for Black nurses were accredited, nationally accredited. So the graduates were firmly embedded in modern professional nursing and fully anchored in macro healthcare. But they also acknowledged the value of the micro components of care, and they had to skillfully navigate that bridge between the community and hospital facility medicine, that bridge between micro and macro care. And it was almost as if to be respected as professionals in mainstream healthcare, they had to camouflage their race, but to be effective in the community, they had to camouflage their class. Many Tuskegee graduates went on to have groundbreaking careers in nursing education, and policymaking, though few stayed in the South because of the social and economic constraints placed on them as Black professional women. That was a factor that led to the demise of the school in 1946. Dr. Kenny, here in his quote, was right in his assessment of the experiences of the nurse midwives. They could never be fully prepared for what they found in the field. Here's a graduate of the Tuskegee School, Maud Callan. She was seconded to the school from South Carolina. And these roads were typical in her 400 square mile beat. And she, at the end of which she said that she found people who did not know the use of forks and spoons. Oh, you probably can't see that very well. The nurse midwives provided a framework under which the lay midwives could safely practice. The nurse midwives were invested in midwifery as a profession, although not in traditional midwifery. And it's inaccurate to assume that just because they were all midwives, they were all supportive and there was lots of camaraderie. As Anita Jones points out on the left, the support of non-professional midwifery was a pragmatic solution to a temporary problem. The nurse midwives appreciated the effort and dedication of the lay midwives, but did not see them as having a long-term future. And in the Alabama-specific addendum, I don't think you can read it. She's basically reinforcing what Anita Jones had said. Again, these are both held in the Reynolds Finley Library. And this conflict between midwives of different types is, it continues today, and it is a serious impediment to the growth of the profession. But the state's long-term goal was physician delivery for all women. And Slossfield Health Centre was an attempt to achieve that goal, among other public health issues. At the head of the clinical side of the project was Dr. Thomas Boulware. He was chief of OB. And his goal was twofold: to prove that good maternity care really did lower mortality, and to prove that Black physicians and nurses deserved full acceptance in the medical community. Slossfield was established in 1939 in one of Birmingham's so-called blighted areas. It was a successful but short-lived venture. It closed in 1948. Its success was attributed to the fact that, as well as providing maternity care and other public health services, educational and recreational opportunities were also available. It promoted a concept of wellness and self-help that was familiar to the Black community, and micro aspects of care were melded into macro. 80% of the women served by the maternity service at Slossfield had more than 6 prenatal visits, and 70% had a postnatal examination too. The resulting improvement in maternal mortality was undeniable. The other prong of Dr. Boulware's objective was in education, and Slossfield's influence here extended well beyond the facilities of the boundaries of the facility. He established a 4-week residency program for Black physicians across Alabama, and a 4-day post-registration program was held twice a year for Black physicians from across the South. Other branches of medicine, nursing, and dentistry were also supported as Slossfield opened its conference centers for professional association meetings. When federal funding began to require a more restricted vision of health, a more modern, medicalized vision, more macro, Slossfield had to follow suit and move away from the traditional concepts of wellness, the more holistic view of health. The desire for a more inclusive, modern care trumped any concession for cultural recognition. And this illustrates the very rapid transition from in expectation for Black women and their deliveries from home to hospital. But hospitals were not a panacea for Black women. They were often segregated into non-maternity wards that negatively impacted the type of care they could receive in labor. Here's the first hospital in America built under the auspices of the Hill-Burton Act. It's now the East Alabama Medical Center. Hill-Burton funds improved the hospital and medical infrastructure across the country, but most specifically in the South, where there were too few hospital beds. The new hospitals typically housed beds for white patients, while the old facilities accommodated Black patients. And for hospital administrators, this killed 2 birds with 1 stone. They could fulfill the obligation to the federal law by providing more beds for Black patients, and the better standards of segregation by having 2 separate facilities fulfilled the local expectations. Those that could now chose hospital birth. It was safer, cleaner, more scientific, and it produced better outcomes, no doubt. It was macro care. And Black women overlooked some of the racially demeaning attitudes and policies. For example, assumptions that Black women feel less pain or they were less deserving of care. But all women, regardless of race, were very dissatisfied with the care they received. Regimentation and procedure ruled. Nurses were described as callous and brutal as they implemented the modern regimes that included enemas and pubic shaves and amnesic drugs and restraints in delivery. Black women lamented the loss of the caring and supportive care they received from the lay midwives. More broadly, though, access to modern scientific medicine was seen by Black women as an entry into American society at large, bringing with it an equality of access that had been previously denied them. So midwifery became associated with backwardness and poverty. the adaptability and the improvisational skills that the lay midwives were so good at were designated as obsolete, and the routine and regimen were considered more modern. And gradually childbirth customs changed accordingly. Midwives no longer ushered women into prenatal clinics, and the clinics were further removed from the community, both literally and figuratively. The cultural difference between the practitioner and patient was huge, with no consideration given to the how effective education was or communication. And often in the often derogatory environment, women felt judged if they were unmarried or poor or perhaps late to prenatal care. Micro elements of care were absent. Thus, the value of prenatal care was relegated, and a technological environment at delivery was seen as more important. There was a general assumption that as long as you had your baby in a good hospital, you didn't need any prenatal care. By the 1970s, maternity care had been under the purview of physicians and hospitals for almost 2 decades, and yet for some, things didn't get any better. The most vulnerable women had lost their connection into the macro system via the prenatal clinics, but thankfully, mortality rates had fallen dramatically, yet Alabama's mortality rate was persistently about half again as high as the national average. So there was still a very uneven distribution of access to care across the state. And the problems were the same: lack of services, lack of physician provider, lack of funds, lack of consistency, lack of a desire to change. Comprehensive studies conducted in the early 1970s revealed severe weaknesses, but as history shows us, making statewide change was very difficult. Alabama is unique in the fact that the Medical Association, MASA, is the Department of Public Health, of which the Bureau of Maternal and Infant Health is part. And within this structure, local boards of health are autonomous. And this in part seems as though it was impediment to a more consistent access across the state. Alabama was under pressure from the federal government in the early 1970s, when some counties had been identified as having the highest infant mortality in the nation. And federal funds were allocated in the form of an Improved Pregnancy Outcome Initiative. In charge and driving the changes at the maternal and child health was Dr. Robert Goldenberg. With a professional background from Columbia and Yale and Duke, he'd never seen maternal deaths until he came to work at UAB. And he tirelessly covered the state, convincing local boards of health of his need for the need for change, and demonstrating that his changes were already bringing some very positive results. The West Alabama Health District, based in Utah, Greene County, was the location for the Improved Pregnancy Outcome Initiative. It shared similar features to Slossfield in its blend of community-based, community-aware services and activities, its attention to the sanitation and environment, and a broader, more holistic view of health. Improvements were seen very quickly. But with about 85% of funding for these maternal and child health services coming from the federal government, in the early 1980s, when spending cuts forced the withdrawal of these more rural services, maternal and infant mortality and morbidity increased again. The adoption of certified nurse midwives for normal low-risk women was one of the recommendations of the reports of the 1970s. This was wholeheartedly supported by Dr. Charles Flowers, who was the first full-time chairman of Obstetrics and Gynecology here at UAB. He was appointed in 1969, and his objective was to move Alabama obstetrics into the modern era. He wanted to provide excellent family-centered obstetrics, in effect reincorporating some of those micro aspects of care, and to improve obstetric education. To use his term, he locked horns with the State Board of Health early and often during his tenure as chairman. It was most often to do with the lack of funding in what he perceived to be a total indifference to maternal and infant well-being. Dr. Flowers' comment in the middle of the slide, "We will no longer be able to say, thank God for Mississippi," reflects Dr. Boulware's assessment of the "here we rest at the bottom of the pile" status from decades earlier. Dr. Flowers proposed that initiating a certified nurse midwife service at UAB would prove beyond a doubt the value of the role. He appreciated the nurse midwife's relationship with women, both in clinic and in labour and delivery. They fulfilled his vision of a more modern, family-centric style of obstetrics, and he insisted that his residents spend a good deal of time working with the nurse midwives. He thought that the inclusion of those soft micro-level components of care, the soft skills, made the residents more effective, thoughtful practitioners. However, he ran headlong into vehement opposition from Massa. He always felt his failure to establish nurse midwives in Alabama somehow undermined his efforts to modernize obstetrics here. In 1976, a new state law mandated that all midwives must be nurses, and it set out guidelines for the role of certified nurse midwives. It was the end of the road for lay midwives, although given the uneven access to care across the state, lay midwifery petered out more slowly in some counties than others. Margaret Charles Smith and Onnie Lee Logan correctly anticipated where the lay midwives would be missed, and that was with women. The meaning of the word midwife is with woman, and the lay midwives were missed not just in labour and delivery, but throughout pregnancy and in all aspects of women's health. The midwife's important role in prenatal education and advocating for women in clinics was now absent, and macro-level systemic changes had made little difference in encouraging Black women to seek early prenatal care. After her years as an active midwife, Margaret Charles Smith continued to be an important resource in her community, and a doctor at the West Alabama Health Center said that because Mrs. Smith knew the families, she was so effective at getting them into care, not just for maternity care, but for all types of medical care. And it reinforces the fact that the West Alabama Health Center got it right in its blend of micro and macro components of care. For certified nurse midwives, though, the grass was hardly any greener. Alabama has never been a fertile ground for midwives of any stripe, as you can see from the slide. With too few physicians, UAB opened a school of nurse midwifery in 1990. Dr. Goldenberg was a keen supporter, but the school ran into similar obstacles as faced by Dr. Flowers a decade or more before, namely physician opposition. And as a result, the school failed to satisfy the national accreditation standards. There were too few clinical opportunities for the students and too few employment opportunities following graduation. The school closed after 5 years. However, a graduate of the 1990 school, Dr. Sharon Holly, who's with us today, returned to Alabama last year and has facilitated the opening of a new school of nurse midwifery. Although many of the obstacles are still present, she is optimistic, I think frustrated, but optimistic that, that nurse midwives can develop a professional space in Alabama. A couple of years ago, the state passed legislation to allow certified professional midwives to practice and conduct home births in Alabama. And this is just my opinion, but I think the activism that forced this change came from women for whom home birth is important. And I don't think it's going to make a huge difference to the majority of women, particularly those women who are finding access to care more difficult. But the legislation at this change is bringing a closer look to nurse midwives. And that's the real way forward, in my opinion, is to integrate nurse midwifery into mainstream maternity care. A nurse midwife in Gainesville is trying to open a birth center in what has been described as a maternity care desert. Not surprisingly, she's running headlong into opposition from the Department of Public Health. And again, the relationship between the Medical Association and the Department of Public Health is being blamed as an impediment. The other side of the argument is a concern about safety and standards of care. But I think the ball is currently in the state's court as far as that issue goes. In conclusion, then, when we look at the history of maternity care from a micro and macro perspective, we can see that neither type of care alone can provide adequate care. Across the century, the highlights have been where micro components of care have been incorporated into the macro system, macro structure. And that's where maternity care has had its best potential for improvement, as shown by Schlossfield, Dr. Goldenberg, Tuskegee, Dr. Flowers, and the nurse midwifery service that time and time again has been proven to improve outcome for all women, particularly those most vulnerable. I think it's only fitting that I close with a prescient thought from Dr. Boulware, who cautioned his profession in the 1980s. He expressed concern that the failure of medicine to address the modern challenges of obstetrics, the macro level challenges of the overdependence of technology and issues of malpractice, would eventually lead to the withdrawal of services and potentially a return to unsupported, unsupervised midwifery, in effect, turning the clock back a century to where we began today. Thank you.
Thank you, Jenny, so much for this insightful and informative lecture. And I'm just delighted that you were able to take an opportunity of the fellowship to conduct your research for the book. So that's wonderful. Yes. And before we open the floor to the questions, I would like to take just a brief moment to personally thank Dr. Finley and the family and Dr. Pappas and all the members of the Reynolds-Finley Steering Committee and our supporters for being here with us today. Your ongoing care and support is just invaluable. So, okay, if we open the floor to questions now, Jenny? Yeah. All right. Okay.
In general, are things getting better now then?
Yes, I look at this topic as a historian, so I'm not sure that I am the right person to ask. I know Dr. Holly probably answer that better.
still have a problem. We have something we need to solve together.
Yeah.
And I think one of the things that we just say, oh, is to combine all of the resources that we can right now. We're missing a big chunk of this state with our community.
It's a work in progress. Here we go.
I think one problem with there was a recent study done about integration of nurse midwives into maternity care, and they've looked at states individually. And Alabama did rank, I think, second from the bottom. But part of the problem with nurse midwives is that it's governed at the state level, so there isn't a federal law that oversees nurse midwifery practice. So each state is left to itself to solve its problems.
I enjoyed your lecture very much. I have two quick questions. The first one has to do with C-section. Can you talk about the relationship between levels of acceptance midwifery and lower level of C-sections? I believe Alabama is the highest, if not one of the highest states that has C-sections. I know that has to do with a broader picture of rural health and maternal health. The second question is, can you say something about what doulas do? I had two kids in Illinois. We had doulas in both cases, but I don't know if that's a term that is part of this history.
In my understanding, I think a doula is, and I may be wrong, but I hadn't heard of a doula until 10, 15 years ago. So in that respect, I think it's a new position, but it's also a very traditional one as well, because it is somebody who provides a traditional support to a woman in pregnancy, and they're gaining, I think, a lot of publicity, and they're very effective, I don't know, healthcare, maternity care worker. But again, in Alabama, I'm not sure what the law is about doula practice. Some states, doulas are reimbursed in through Medicaid, but I'm not sure about Alabama. As far as cesarean section rate, I do know when Dr. Boulware had his maternity service at Slossfield, he had a very low cesarean section rate, and he always said that you get a higher rate of cesarean section with an obstetrician who is less confident in his ability. So yeah, his section rate was very, very low at Slossfield, and his maternal mortality was almost zero. I have it in my notes. He did make a quote that he had zero maternal mortality. I think he meant that some women died. It wasn't really related to pregnancy or labor. So he had a zero maternal mortality. Oh, Edith. Yes. Yes, there's an anecdote. I didn't have time to discuss all of these little the anecdotes from the lay midwives, but the midwives had to have their bags inspected at every midwife meeting, and the public health nurse would inspect the bags, and everything had to be exactly how it was stipulated in the handbook. And there's a story, I think, from Georgia. A midwife she was at the meeting, she was having a bag checked, and the public health nurse lifted up the lining, and there was a gun underneath the lining. And this midwife had been out on a delivery the night before, and she'd taken it for her own safety, completely forgotten that she had a gun in her bag. And she had to run out of the room. She felt so ashamed. But yeah, the bag checks were taken very, very seriously. And there was even a prayer that the midwife said prior to the bag check to make sure that the person was lenient. Thank you.
Thank you again, Jenny. I hope all of you will join us for the reception, which will be held immediately after the lecture here in Volker Hall. And we have two special highlights for you today at the reception. One is an art activity with an artist, Annie Kramer Buttress, who's a Birmingham-based artist. Annie has exhibited nationally, and she is just about to also exhibit internationally at the Venice Biennale. So we are honored to have her here today. And the other highlight is an unveiling of the architectural drawings for the future historical collections gallery, which we hope to create on the second floor of the Lister Hill Library. We are currently fundraising for the gallery. And I truly believe that it will be absolutely transformative in how we can exhibit, curate, promote, and showcase our incredible historical collections at UAB. With that, thank you so much for coming, and we will see you at the reception. Thank you.